So hello guys, welcome back. So today we are going to see vernal keratoconjunctivitis VKC or spring catara or warm weather conjunctivitis. Okay, that is not cataract here, it is conjunctivitis. Okay, wrong here. So it is a most important question asked 5 times in exams. Okay, we are divided into etiology, clinical feature, pathogenesis, differential diagnosis, complication management. Okay, I didn't make notes of VKC because this topic itself is very much important. That's why we will read it from textbook only. VKC. Okay, VKC is a recurrent bilateral interstitial, self-limiting, allergic inflammation of the conjunctiva having a periodic seasonal incidence. Okay, it is a recurrent bilateral interstitial self-limiting allergic inflammation of the conjunctiva having a periodic seasonal incidence. Okay, it is a type of allergic conjunctivitis. Okay, you can see allergic conjunctivitis definition is it is the inflammation of the conjunctiva due to allergic or hypersensitivity reaction which may be immediate, that is humoral immunity, or delayed cell mediated immunity. Okay, there are more than 10 types. Example, simple allergic conjunctivitis, etc. Vernal keratoconjunctivitis is one of the allergic conjunctivitis. Okay, so we will see into it. It is a recurrent bilateral interstitial self-limiting allergic inflammation of the conjunctiva having periodic seasonal incidence. Okay, what is the etopathogenesis? VKC is found in the individuals with predisposed atopic background. Okay, previously it was thought to be type 1 IgE mediated hypersensitivity reaction due to pollen grains. Okay, but now it is characterized by T helper 2 type lymphocyte alteration that the exaggerated IgE response to common allergens in the secondary event. Okay, previously it was a type 1 IgE mediated hypersensitivity reaction due to pollen grains, but now it is a Th2 lymphocyte alteration and exaggerated IgE response to common allergens. Okay, what is a predisposing factor? It is more commonly seen in 40 to 20 years 20 to 40 to 20 years of boys. Okay, more common in summer, that's why the name is spring catara, that is warm weather conjunctivitis. Okay, climate more common in tropics, and other atopic manifestation are eczema and asthma associated with 40 to 75% patients with VKC. Family history of atopy is found in 40 to 60% of patient. Okay, allergy is some kind of a hereditary, because hereditary type, that's why it is more predominant in family members. Okay, what is the pathology? Okay, first the conjunctival epithelium. Conjunctival epithelium in the papillary region contains large number of mast cell eosinophils and undergo hyperplasia, sends down projections into the subepithelial tissue. Okay, that erodes downward something type. Adenoid layer shows a marked cellular infiltration by eosinophils, plasma cells, and lymphocyte histiocytes. Fibrous layer show proliferation and which later undergo hyaline changes. And conjunctival vessels show proliferation, increased permeability, and vasodilation. Okay. These pathological changes leads to the formation of multiple papillae in the upper tarsal conjunctiva. Okay, that is cobblestone appearance. You must be knowing. Okay, cobblestone appearance is a characteristics of VKC. Next, coming to what are the clinical features. Clinical features are symptoms of spring catara are characterized by marked burning and itching sensation. Marked burning and itching sensation, which is usually intolerable. Itching is more marked with palpable form of the disease. Okay, itching is more marked with palpable form of the disease. Other features are mild photophobia, lacrimation, stringy ropey discharge, and heaviness of the lid. Okay, in your exam the question will come like there is irritation of the eyes with mild photophobia, lacrimation, and stingy ropey discharge. Okay, ropey discharge is seen in VKC and cobblestone appearance in VKC. Remember it. Signs of VKC are it is divided into 3 types: palpebral, bulbar, and mixed type. Okay, first we will see palpebral. The palpebral VKC means the signs are seen in palpebral part of the conjunctiva. Okay, usually upper tarsal conjunctiva or upper tarsal conjunctiva of both the eyes is involved. The typical lesson in the presence of hard, flat-topped papillae arranged in cobblestone or pavement stone. Okay, along with the conjunctival hyperemia. Let me show you the picture. Okay, here is the picture. You can see cobblestone appearance. These are the cobblestone appearance like pavement type, and this is the white ropey discharge. Okay, when these papillae, okay, these are papillae, not follicles. Okay, remember, when these papillae get hypertrophy, they are converted into cauliflower like exercise of giant papillae, and they are associated with white ropey discharge. Okay, now coming to the bulbar limbal VKC, it is characterized by dusky red triangular congestion of the bulbar conjunctiva in the palpebral area, and the limbal papillae occurs as gelatinous thickened confluent accumulation of the tissue around the limbus. Okay, presence of discrete whitish raised dots around the limbus, that is Horner transfer spots. Okay, let me show you. Okay, here you can see the raised limbus. Okay, this is gelatinous thicked confluent raised limbus is seen along with triangular shape hyperemia. Okay, this is triangular shape hyperemia. And next is the Horner transfer spots. Okay, Horner transfer spots are characteristics of vernal keratoconjunctivitis. Okay, these are gelatinous membrane around the limbus, VKC. They are whitish in color. Horner transfer spots around the limbus. Okay. Next, mixed type means it includes both palpebral and bulbar form. This VKC includes something called as vernal keratopathy. Okay, vernal keratopathy means corneal involvement of VKC. It involves a few things, that is superior punctate epithelial keratitis. Superior punctate epithelial keratitis involves upper cornea. It is usually associated with palpebral form of the disease. It is caused by medication form of inflamed tarsal conjunctiva, and the lesion always stain with rose bengal and invariably with fluorescent dye. Okay, that cobblestone will rub against the cornea and cause a superficial punctate epithelial keratitis. Next is epithelial microerosions, leaving Bowman's membrane intact, result due to coalescence of punctate epithelial lesions. Okay, these punctate epithelial keratitis, like small will be there. Later they will coalesce and form a big ulcer type of thing, like epithelial microerosions. Okay, there will microerosions are there. Next, vernal corneal plaques result due to coating of bare areas of epithelial microerosions with layer of altered exudates. Okay, first there will be small holes, then they will coalesce and form a big hole, then there is some accumulation will be there, then they form plaque. Okay, this is the scene. Next, ulcerative vernal keratitis, shield ulceration present at the shallow transverse ulcer in the upper part of the cornea. The ulceration result due to enlargement of the epithelial microerosions. It is a serious problem which may be complicated by bacterial keratitis. Okay, there is subepithelial scarring in the form of ring scar, and pseudogerontoxin is seen. Okay, pseudogerontoxin can develop in recurrent limbal diseases, and it is characterized by classical Cupid's bow outline. Okay, you read once again. There is superficial punctate epithelial keratitis, then they will coalesce and form epithelial microerosions, and then there will be coating on that and form vernal corneal plaques, and then there may be shield ulceration formation. Okay, and subepithelial scarring and pseudogerontoxin can also be seen. This is a picture. Okay, next, Horner transfer spots, already you have seen. Next, this picture you can see cobblestone appearance. Okay, cobblestone appearance in the upper tarsal conjunctiva. They are hexagonal papillae. Okay, they are papillae, not follicles. Okay, and next there is a gelatinous membrane, and Horner transfer spots are seen. Okay, here you can see Horner transfer spots, and there is triangular congestion here. Okay, triangular congestion, dusky red triangular congestion. This upside picture is a plaque, that VKC plaque, no, vernal corneal plaque, and downside is a shield ulcer. Okay, plaque and shield ulcer. Have a look. How is plaque is formed? First, after microerosions filled with some material, then it form the plaque. Okay, and there is the shield erosion. Next, what are the clinical course? Disease is often self-limiting. And usually burns out during 5 to 10 days. Differential diagnoses are true. One is trachoma. Trachoma, because we need to differentiate these papillae from the papillae which are seen in trachoma. Okay, in trachoma both papillae and follicles are seen. Next is atopic keratoconjunctivitis. Now, what is the treatment we will give? Okay, treatment, main treatment is topical anti-allergens and anti-inflammatory drugs should be given. Okay, first, dual action antihistamines and mast cell stabilizers should be given. That is the first line treatment of mild to moderate cases. Dual action antihistamines should be given in the first line. Those are olapatidine, azilastine, and bipotastine. Okay, mast cell stabilizers like sodium chromoglycate drops 3 to 4 times a day. Okay, this sodium chromoglycate prevents mast cell degranulation. Okay. Next, we should give topical steroids, effective in all forms of VKC. Because allergy is there, means we should give steroids. You should remember this. Okay. Monitoring of the intraocular pressure should be seen, because it's steroid-induced glaucoma. Okay. Steroids like fluoromethalone, loteprednol, prednisolone, betamethasone, dexamethasone can be given. Loteprednol and fluoromethalone are the safest. You should remember retoprednol and fluoromethalone are the safest. Okay. Topical immunomodulators are given, like cyclosporine and tacrolimus. Immunomodulators like cyclosporine and tacrolimus. Okay. Other things are topical lubricating and mucolytics should be given. Okay, as the cobblestone things in the upper tarsal conjunctiva rub against the cornea. Okay, to avoid that we should maintain moisture. That is artificial tears we should given. That is carboxymethyl cellulose. Okay, to provide smoothing. Next, acetylcysteine 0.5% used topically has mucolytic properties. Okay, acetylcysteine for mucolytic. Okay, for moistening carboxymethyl cellulose. Next, systemic therapy. It is required in severe cases only. That is, oral antihistamines provide some relief from itching. Okay, oral antihistamines provide some relief from itching. Oral steroids for short duration can be recommended. Others are treatment of the large papillae. Okay, for large papillae we should give subtarsal injection of long acting steroid. Okay, or we can do cryo application, or surgical excision can be if extraordinarily large. Okay, subtarsal injection of the long acting steroid, cryo application, surgical excision. Those papillae can be removed. Okay, supportive measures are we can give dark goggles to prevent photophobia, cold compress for soothing effects, eye rubbing should be avoided, and change the place from hot to the cold area. Okay, because hot means that's why only spring catara word is there. Okay, you can remember. Next, treatment of vernal keratopathy. Okay, for punctate epithelial keratitis we should give steroids. Dose of steroids should be increased, and with large vernal plaque, surgical excision of that plaque should be given, that is superficial keratectomy. And severe shield ulcer resistant of medical therapy may need surgical treatment in the form of debridement, superficial keratectomy, excimer laser therapeutic keratotomy, and amniotic membrane transplantation to enhance the reepithelialization. Okay, these are the things. Okay, for vernal keratopathy. See you in the next video. Please read this VKC, and it is a very important question, and it is very repeatedly asked in your exams. Okay, that's it. See you in the next video. Until then, Jai Hind, Jai Bharat. Bye bye. Have a look at this.